theme of this is management of large and locally advanced renal masses, past, present, and future. I do want to dedicate this talk to Dr. Novick and his memory. He passed away 15 years ago, and 15 years ago, 2 days ago. So a great leader and a mentor and a visionary. So again, we'll just have a contextualization, echoes from the past, where we are and where we kind of want, at least the Derweesh-centric view in terms of where we want to take the field going into the future. So the first thing I want to talk about is, I think, talking about changing of the management paradigm in clinical T2 renal cell carcinoma. T2 renal cells are up to about 25% of renal cell cancers. The standard of care has been historically radical nephrectomy. And this is actually Dr. Novick's initial series from 1999, 21 patients, about a 10% local recurrence rate, about 29% metastases, but pretty decent survivals. And these numbers still hold up despite the time. So the question is what happened next? And I think that there's always been a lot of concerns about these larger partials, both in terms of oncologic efficacy as well as complications. These were our data, and when they came out, this is in 2014, 202 patients, 80 partials, 122 radicals. And these were 2 companion papers that were written by Ryan Kopp, who's now at OHSU. Really no difference in terms of the overall survival and the cancer-specific survival and progression-free survival. You can see that in the Kaplan-Meiers right here. The difference wasn't between radical and partials. It's that when we looked at this with respect to renal scores greater than 10 tended to do worse than the lower renal scores. And disease progression was not associated with a type of surgery, but really more so with things such as nephrometry score and Furman grade, presence of transfusion. So we went ahead and we concluded at the time that this was oncologically effective. This was the largest series at the time, and we looked at, and the companion paper, as I said, was published about a year later. And if I point your attention here, you can see the delta GFRs with the radical were about 20, and with the partial were about 12, and again, increased in incidence of de novo GFR less than 60. This ultimately led to a meta-analysis that was published in European Urology looking at 21 comparative studies, and this was in the T1B and the T2 space. 4 of these were in the T2 space. In any case, as you can see, really the complications and the blood loss favored the radical. However, really no difference with respect to tumor recurrence or cancer-specific mortality. Delta GFR and onset of CKD favored the partial nephrectomy. And again, you can see the Kopp paper in these multivariables. So we concluded at the time that these data suggest that partial may be feasible for select T2 masses and may provide acceptable oncological outcomes in patients that are comparable to those of radical nephrectomy while conferring functional benefit. I'm going to kind of just show some of this. I'm just going to show a little bit of some of the stuff that we were doing, and this was at the time. And again, this was actually robotic cold ischemia, and this is being narrated by Zach Hamilton, who's now the chair at St. Louis University, one of our fellows at the time. We used ice. We put it through a separate port, and these were the larger, more complex partials. I'll just get to the... And again, I think that as you can see, this is just kind of pushing ice around there. We'd apply that a couple of times during the procedure. We'd have communication with anesthesia to make sure that the bear huggers are on. And as you can see, again, just a cold ischemic resection, reapplication after the resection, and then the standard rhinorrhaphy. And I'm just going to kind of push through this just because I think that we want to And again, molding the rhinorrhaphy here with some flow seal, followed by placement of this cottonoid suture. This cottonoid sponge to mold it prior to placement of more hemostatic agents. And the accessory port is the where the ice goes in. So I think that now I'm going to give a shout out to Dr. Ghali. The next question that to be asked was, of course, well, okay, great, you can do these partials and you can do them robotically. Well, how do they compare to your robotic experience, or how does the robotic experience compare to the open? And as you can see here, this was a paper that came out in 2020. There's really, again, single surgeon experience, 59 robotic partials, 91 open partials, decreased rates of 30 and 90-day complications, as well as, most importantly here, if you take a look, urine leak rate reduction from about 10%, 9.8% to 1.7%. No significant difference with respect to positive margins. So I think what we took away from this was that, sure, there's an element of selection bias here, but what we're showing here, and when we're selecting these patients, we are showing an improvement over historical series or an open series that's also evolving at the same time. And so the next question that we asked was, well, that's fine. Robotic partial for these larger masses is feasible and maybe superior to the open in terms of reducing morbidity. What about the gold standard of a radical nephrectomy, a minimally invasive radical nephrectomy versus partial nephrectomy? So this came out later on in the same year, 2020, robotic partial versus minimally invasive radical for T2A mass. And this was a propensity score matched retrospective analysis. There were 1-to-2 ratio, 216 robotic partials, 432 MIS radical nephrectomies in the T2A space. And again, something similar to what we saw with the opens, similar oncological outcomes, superior GFR preservation with respect to reduced rates of de novo stage 3 and stage 3B CKD. And interestingly, when we looked at the patients who were upstaged to T3A disease, as you can see here, incidental upstaging, you saw no difference in the overall and the disease-free survival. And importantly, and again, I wanted to show this, really no differences in the intraoperative complications cleaving greater than or equal to 3 complications or readmission rates. So robotic partial is not just feasible, it's also oncologically efficacious and can provide decreased morbidity profile with respect to the open partial, and open partial being also oncologically equivalent to radical. So what was the impact on the guidelines? And I'll just kind of show these graphics here for a second. This is in 2015. You can take a look. Stage 2 to 3 radical nephrectomy is really listed as the only one. By the 2017, you see stage 2-3 radical nephrectomy or partial nephrectomy if clinically indicated, whereas with the 2022, you take a look at the stage 2, partial nephrectomy is there, partial or radical nephrectomy. So then what about the AUA guidelines? These were the guidelines that came out in 2017. And again, the big statement with radical versus partial was well-defined selection criteria with respect to radical nephrectomy. Patients with an aggressive appearing tumor, no pre-existing CKD or proteinuria, and a normal contralateral kidney that can provide a baseline GFR greater than 45 should be considered for radical nephrectomy. Whereas beyond this, most T1B and T2 tumors can be considered for partial nephrectomy. And again, the wording was kept very similarly with the newest iteration of the guidelines that came out in a couple of years ago. And again, the same criteria. So in addition to increased oncological risk, the following three criteria are also, if they're also present, then radical is actually preferred. And so maybe a slightly stronger tweaking of that wording, but otherwise pretty similar criteria. High complexity, tumor complexity, where a partial nephrectomy would be challenging even in experienced hands. No pre-existing CKD or proteinuria, and also a normal contralateral kidney that will likely provide a GFR of greater than 45. However, what about the tumors in patients with CKD or proteinuria and in which a nephrectomy would drop GFR less than 45? Or let's say a solitary kidney in which a partial nephrectomy would be challenging even in experienced hands? And I want to focus on this question, but let's just hold that thought and come back to it. So we didn't just stop at the T2 partials. The question is what about the clinical T3 renal masses, the T3As? This was something that was published by us as part of a multi-center study. Kendrick Yim led that. He's actually a resident now at the Brigham. And again, this was a single-arm study, clinical T3As. About 40 to 50% of them were overall had renal vein thrombi of some type. This is a renal vein thrombus that was excised and shows the repair of the vein and ultimately the excision and what it looked like. And actually, I'm going to show, this came out as a video of some of this. Again, another shout out to the good Dr. Ghali. So again, this is an endophytic tumor. This one is a segmental thrombus. I always give a lot of redundancy to the collecting system in terms of a technical pointer there. And you've got to put these in the bag immediately. I'm just going to speed through this. And again, you see the regular corticomedullary suture, prior to closure of the This was being narrated by Devin Patel, who's in Arizona right now, another one of our former fellows. And again, Dr. Ghali found his way on this paper as well. So we'll continue here. And let's see here. Let's go to the next slide here. So then we asked ourselves, all right, let's take it a little further. What about into the IVC? And I think that you could take a look at this video here. These are feasible for select tumors. And we have an evolving series of these that we're readying for publication as well. So this 65-year-old woman, actually, CKD3 had presented with bilateral segmental PEs, reduction in her performance status, and ultimately had a level 3 thrombus, if you take a look at it right here, and an infiltrative tumor. She was ultimately not noted to be a surgical candidate and was started on a clinical trial of nivolumab and ipilimumab. After a year, there was quite a dramatic partial response and marked improvement in her performance status. Given her CKD, she was offered a open partial with an IVC tumor thrombus. I'm going to show you all the, this was the subsequent post treatment and pre-operative IVC thrombus. As you can see, it gets into the IVC, quite a dramatic reduction in size here, and some good preservation of renal parenchyma. We do this through an anterior approach, what we call a reverse hockey stick incision. That lateral portion can sometimes come down a little further depending on the size of the tumor or where the liver lies. And I'll roll this here. Again, this has to observe the anatomical and the surgical principles of the operation, including inflow control there, as well as proximal and distal and contralateral renal vein control. And with that, then ultimately mobilization of kidney. This patient had an intraoperative renal ultrasound to delineate margins. There we were trying to actually kind of pull that thrombus in, but we couldn't really milk it back in. And ultimately the patient required having the formal clamping. And there it looks before we did the resection and applied the clamps. And see, I think it's the next slide here. So here's the very nice schematic from actually one of our residents who does really good illustration work. And so let's see here. And again, we start the resection away from the thrombus, and there it is. And then we march towards the thrombus with everything clamped. And you see the thrombus coming in right there. Ultimately, when the thrombus is removed and the renorrhea is conducted, there was an L-shaped reconstruction of the anterior aspect of the vein, as well as of the vena cava with a proline, with a 6-0 proline. We resected a portion of the vena caval ostium and sent that off as a separate margin as well, or the how can I say this more properly? The confluence of the renal vein with the IVC. And again, you're seeing the standard open closure with flow seal, fibrillar, after collecting system entries and segmental vessels, the cortical defect gets closed. And this is a technique that I've kept from the time of Dr. Novick. And you'll see the picture. Here are the clamps being removed and the Renals being removed. And there it is, my homage to Dr. Novick. So there's a specimen with the resected portion of the vena cava wall and the tumor thrombus. And again, this is what it looked like about 3 months afterwards. This patient continues to be disease-free, almost more than 2 years out, with excellent preservation of overall renal function. So I think when you take a look at this, the present is the treatment of these types of tumors that are higher risk with adjuvant therapy, the pembrolizumab Keynote 562 study that showed a reduction in cancer-specific or reduction in disease-free survival of about 43%. It's part of the checkpoint inhibitor era, first with first line for metastatic renal cell, and now this for high risk for localized recurrence. The interesting thing is what about neoadjuvant therapy in this setting? And certainly neoadjuvant therapy started as a strategy to permit surgical debulking or potentially, in selected instances, partial nephrectomy. This is we're expecting publication or acceptance of this very soon. These are the interim analysis for Padres. This is prior axitinib as a determinant of outcome prior to imperative indication partial nephrectomy. This is a clinical trial, a phase 2 open label between our center and the Cleveland Clinic. So the study is funded by Pfizer, and this is my conflict of interest, by the way. So again, up to 25% of patients presenting with renal masses have renal insufficiency or another imperative indication for nephron-sparing surgery. And previous data showed that tyrosine kinase inhibitor therapy can reduce the primary tumor size by about 20 to 25%. So we asked ourselves, again, going back to that question, in these patients where there is an imperative indication, however, that partial nephrectomy is going to be complex even in experienced hands, can we facilitate a partial nephrectomy? So, inclusion criteria, baseline CKD stage 3 or functional kidney, anatomical functional solitary kidney, bilateral synchronous disease, and a renal nephrometry score of greater than or equal to 10 with proximity to the renal hilum, and where radical nephrectomy is going to lead to stage 3 BCKD. This is the patient subgroup that we chose to enroll in this study. And this is the schema. Again, they needed to have a biopsy to confirm clear cell renal cell carcinoma before starting. We assessed tumor response with RECIST criteria, ability to perform partial nephrectomy after TKI therapy, as well as functional issues such as avoidance of dialysis, severe CKD or moderate to severe CKD, or GFR reduction of greater than 50, and complications, of course. So this is the schematic figure here. Again, a patient with imperative indication partial going into the renal vein. With 8 weeks of axitinib, ultimately was able to shrink it down to a branch of the renal vein, had a open partial nephrectomy, and ultimately this is what it looked like. Interestingly, the other kidney ended up developing a smaller mass that ended up undergoing a robotic partial nephrectomy. The guy is now about 5 years out from his initial surgery, and there's no evidence of any metastatic disease, and his function is beautifully preserved. So again, this was the patient and tumor characteristics. These are the toxicities. Again, most common was hypertension, or worsening hypertension, or fatigue, hand-foot syndrome, and some of the other things that you see with taste change or mucositis or diarrhea. So if you take a look at this, The axitinib resulted in about a 19% reduction in median tumor size from about 7.7 centimeters to 6.3 centimeters, a reduction in the median renal score from 11 to 10. Interestingly, if you take a look at this, 20 out of these initial 26 patients who were enrolled were either a stage 3A or a stage 3B. And ultimately, you did have some pathological downstaging, where some of these were downstage to a T1B or even a T1A. This is the impact on the renal nephrometry score. Surgical outcomes, again, partial nephrectomy was feasible in 19 out of these 26, about 73%. Most of these were done open. There was about a 23% major complication rate. Those are mainly actually urine leaks. Negative margins were achieved in 24 out of the 25, actually, that ultimately underwent successful surgery. One of these operations was ultimately terminated or aborted. So if you take a look at this, the median eGFR change at the 3-month mark was about 8.3%, and about 2 patients had a reduction in GFR of greater than or equal to 50, and 1 ultimately actually did progress to long-term dialysis dependence. So the key points here is that neoadjuvant axitinib can safely and effectively downsize tumors and reduce complexity in large and complex renal masses. Neoadjuvant axitinib therapy may facilitate partial nephrectomy in a unique subset of high-risk patients who have no other viable strategy for nephron-sparing surgery, and pre-surgical systemic therapy may also allow preservation of renal function in patients that otherwise could not undergo nephron-sparing surgery. So Padres continues to accrue with a target goal of 50. We're at about 33, 34 right now. Expanded indication for neoadjuvant therapy followed by partial nephrectomy in a randomized trial comparing TKI versus partial nephrectomy or TKI in patients with lower stage disease to evaluate oncologic outcomes, or neoadjuvant therapy prior to partial nephrectomy in patients with localized renal cells. I'm just gonna now, this is kind of the future where we are. This is actually an evolving clinical trial proposal, personalized versus neoadjuvant therapy for high-risk localized RCC. This was initially called Padres 2, but it's now being called Petra. This is being elaborated by myself and Dr. Campbell. So again, we're going to use the same group of patients that right now are candidates for the adjuvant therapy. So the high-grade T2Bs, T3 or T4s, and we're going to compare patients with a personalized neoadjuvant approach versus let's say a traditional, let's say upfront TKI therapy. Patients can be candidates not just for partials, but also for radical nephrectomies and thrombi and high-risk localized disease. So, but if we take a look at this, and just as a background, the response rates of axitinib or pembrolizumab were around 20 to 35% or 36, 37% by themselves, with some significant toxicities. Whereas if you take a look at the combination, Axi-Pembro, the response rates are 60%, but the toxicity kind of climbs up to almost 80%. So the question is can we improve these response rates by appropriate pretreatment selection? And can we reduce toxicity by not exposing patients to agents that they may not respond very well to? Just a couple of quick papers in terms of background. This was a paper that was ultimately funded by some research from a company called Boston Gene. And what they did was they looked at a peripheral blood sample in addition to a biopsy. They looked for things such as TILs, tumor-infiltrating lymphocytes, necrosis in the tumor, as well as a PBRM1 mutation. And as you can see, you can risk stratify patients, and patients without tumor infiltrating lymphocytes, with with necrosis and without a PBR1 mutation, do far worse than patients who have TILs or necrosis or a PBRM1 mutation. Similarly, you can predict response to TKI therapy. So analysis for VHL mutations can also predict response to TKI. And if you can see here, patients who are VHL mutated do far better than VHL wild type in a metastatic renal cell cohort. So the question is can we combine analysis for VHL and PBRM1 and H&E stains obtained during pretreatment biopsy to then personalize neoadjuvant therapy? People talk about personalized cancer therapy, but if you take a look at this, none of the trials in renal cell, adjuvant, neoadjuvant, metastatic, localized, has really tried to take a personalized approach specifically for renal cell patients. So the hypothesis is that a personalized approach can result in improvement in response in monotherapy. So VHL mutated in TKI or in immunotherapy agents, TIL plus, necrosis minus, and PBRM1 mutated, and improved response in combination therapy as well. So predicted with respect to a power analysis in a traditional arm, we predict a axitinib monotherapy of about response rate of about 27%. In the personalized arm, in the pembrolizumab monotherapy, about 55%, axitinib 45%, and a combination of axi pembro about 80%. And if you take a look at this with the standard alpha, beta, and power calculations for a randomized phase 2 study, you'll get a total of 54 patients. So again, it's a phase 2 randomized study. High-risk localized clear cell renal cell cancer. 2 arms is a traditional arm, axi for 9 weeks, and a pembrolizumab, a personalized arm. It's based on prediction of response to IO. There can be just a solitary TKI arm if you have VHL only mutations, but not the PBRM1, loss of function, or the tumor infiltrating lymphocytes or necrosis. If you have them both, you can get both. If you just have the PBRM1 loss of function mutation, you just get the pembrolizumab. So these would be the 3 different arms for the personalized, the 3 different subgroups for the personalized arm. Primary outcome would be tumor size reduction by RECIST or change in renal nephrometry score or clinical downstaging. And secondary is the ability to perform planned surgery without adjacent organ resection, negative margin with safety indices such as avoidance of Clavian 3 or greater complications or need for multiple blood transfusion. And of course, looking at differences in response, toxicity, and cost. So this is the schema. This has been something that's presented to the SUO CTC, renal cancer clinical trial committee, and is in the process of we're obtaining funding for it, and so this is something that we hope to start out hopefully in the next year or 2. And finally, I'll just want to switch, and this is actually a paper that's in press. The question that gets asked, well, how can we predict GFRs of less than 45? Certainly, there's a few different nomograms that look at tumor volume or kidney volume and use sophisticated software. And what we decided to do here, and this is in press with Urologic Oncology, was just to use preoperative demographic parameters and take a look at this. And so we designed both a nomogram for AKI, so acute kidney injury after radical or partial. That's defined as an increase in drop in GFR of less than or greater than or equal to 25%, as well as CKD stage 3B, so a GFR of less than 45 at last follow-up. And here are the 2 nomograms. And again, the predictive area under the curve for the AKI was 0.8, and for the CKD stage 3 was 0.76. Interestingly, AKI was predictive of CKD3A, but not 3B, which was one of the findings. In terms of the size of this cohort, was from 6 centers, more than 1,500 patients. It's the largest look at post-surgical AKI, and actually also the largest look specifically at CKD greater than 3B, greater than or equal to 3B. Interestingly, the Rathi et al., which used sophisticated computer software, and that was Steve Campbell's recently published data, had an area under the curve of about 0.8 for CKD3B. So this is a much simpler nomogram, very quick to do, and again, 0.76. And here's an example of the decision making. For example, you have a 65-year-old diabetic male with a GFR greater than 60 starting out with. Your probability of CKD greater than 3B, for example, with a partial, maybe about 16%, with a radical, maybe about 30%. Now, what is this? Is this going to be the only arbiter? No, but it's certainly another piece of information to help guide shared decision-making in a point-of-care fashion. And the interesting thing is in this is that a lot of these other nomograms are looking at prediction of function after just partial nephrectomy. Our use of a radical nephrectomy cohort in this allows discernment and different scenarios to be discussed with the patient. And again, risk of partial and also risk of functional degeneration. So I think on that note, I think that I've come to the end. And I want to thank you all for your time. And for the opportunity to present today and take some questions.
Really great to see. So fun to see this body of work sort of come together in this talk. So thanks for a great talk. I am pretty struck by the downstaging you all saw in the Padres trial and the pathologic results from Padres so far, especially since the TKIs have been a little bit disappointing in the adjuvant setting in terms of having a signal, for some oncologic efficacy. So I'm curious what you make of that, and if you think that, the pathologic downstaging you see is going to translate to a real outcome difference for patients like we see in bladder cancer versus just sort of an artifact or something from the treatment.
Again, I think that this is that's the next question that needs to be asked, and that's what you need with longer term follow-up. It's interesting because we recently also published a multi-center study looking at partials or radicals. This is retrospective, that was in clinical genitourinary cancer with, mostly just either IO or IO-TKI combinations. And you do see a clinical or a pathological downstaging of somewhere around 20 to 30%. I think the difference with these, with this subgroup of patients is probably because, again, this is localized or locally advanced disease. So you may see a more favorable effect in these tumors that may have less machinery to resist an anti-angiogenic agent. And so that's how I would look at it, but I think you need more data. Absolutely.
Quick question for the people receiving the neoadjuvant axitinib. I saw that in the inclusion criteria that people with bilateral tumors were included. Did they have surgery for both tumors at the same time? So when you're holding the neoadjuvant axitinib, is the contralateral tumor left in place and then dealt with later, or do you treat both in the same day? And if they're left in later, what happens to the contralateral tumor while the axitinib is being held?
Yeah, that's a very important question. In the first 26 patients, we did not actually have a situation where we had two synchronous tumors that were both complex like this. So I think that in situations where there's bulky disease, and that you really are needing to go after them, and you're concerned about that phenomenon, a bilateral approach is indicated.
As a follow-up to Dr. Ghali's question, what's your sense of, even without neoadjuvant therapy, the difference between clinical staging and pathologic staging for these patients? So, in terms of just, we see pathologic downstaging that's attributed to the neoadjuvant drug. What do we actually expect in terms of clinical staging to pathologic staging without neoadjuvant therapy? I.e., how accurate is our clinical staging, and what impact do we actually think is the drug versus inaccuracy in clinical staging?
I think that and again, I'm going to be referring to that clinical genitourinary cancer paper that was recently published by our group. The concordance rate is somewhere around 80%. So it's actually pretty. If you have an experienced radiologist, or if you yourself are pretty good at looking at these, you're going to be able to see that. I think that it was something that did strike us as being more impressive than we anticipated initially. I do think that downstaging, at least with these tumors in the neoadjuvant setting, allows full resections. The question is the longer term data, aside from allowing full resections, is that really going to have an impact? Now, we actually have a propensity matched analysis comparing patients with neoadjuvant versus adjuvant therapy. Again, localized disease, from a consortium that we have with Tokyo and Emory. And it's interesting because what we found was that in the adjuvant setting, IO was superior to TKI therapy. In the neoadjuvant setting, actually, they're pretty equivalent. And overall, neoadjuvant does better than adjuvant therapy. Again, these data are going to be presented at the SUO and are currently unpublished, but we're about to submit for publication. But these are really, really important questions. And I actually think that the future of treatment in these patients, just like with upper tract urothelial, there should be both an adjuvant option for some patients, but also I think patients can gain benefit from neoadjuvant therapy.
Hey, Ithaar, Dinesh Singh here. Thank you for that talk. A question for you that came up when you looked at the proposal of your study and the power of the study. I was struck by how small a number that was. And a multifold question. One, there's not that many sporadic tumors that are going to be VHL positive. So I wonder if that number is low, or if you could use to predict TKI response, use other markers like HIF-1 alpha staining to increase that. And two, what is going to be the protocol for the IR people to biopsy these prior to getting on to therapy, to get an accurate and good sense of how much white cells are in the tumor and PD-L1 staining? Because of the heterogeneity through a small 18-gauge needle, it may or may not accurately predict that.
And Dinesh, that's a very good question. And again, this is a protocol that's currently within it's in the process of being refined. In terms of we have to kind of ride a fine line with these tumors, and there is tumor heterogeneity, and that's going to be one of the limitations of this type of study. You can't really sit there, and I know that Steve Campbell did the ex vivo study where he poked kidneys about 6 or 10 times and demonstrated heterogeneity. You can't really do that, and there's not going to be an review that's going to allow us to do that. I think that we can. What we're looking at here is about a four core maximum in this type of circumstance with these larger tumors. I think your point about using other markers than just, for example, VHL mutations is valid. Our institutional data with sporadics is probably about is closer to about 20 to 25%. But I think that, again, the other question is it's a very novel protocol. As a proof of principle, should we just go with should we go with the single arm and see if we can get people on board to enroll people and show that we can do this and get good results?
Ithaar, this is Isaac Kim. I thoroughly enjoyed your presentation. So I got just a quick question about the neoadjuvant, the protocol itself. So always when we're developing this neoadjuvant treatment protocols, the duration of treatment up front is of some question. So in your Padres analysis, did these patients get some sort of a standard treatment, or did you have an intermittent imaging to show some sort of downstaging for surgery? And how is it impacting your the trial design next? And are they getting again fixed treatment, or is it going to be some sort of a imaging response that you're looking for before proceeding with surgery?
Dr. Kim, thank you for the kind words. With Padres, we had an 8-week protocol with the axitinib. We also obtained imaging about 1 week before surgery to assess response, but it was a straight up 8-week type of protocol. I think when you start looking at these combination regimens, they're going to be longer in time, particularly if you're going to be going with for example, an agent like pembrolizumab, where you may need 6 months, or if you're looking at Nivo or something along those lines, it's going to be at least 3 months. We are not planning to gauge response just based on or continue treatment. We're planning to do this as a variable, as a fixed regimen, and to expand, let's say, for example, axitinib from about 8 weeks to about 12 weeks. Excuse me. But I think that that's actually a good point to make in these types of things, because there are some patients who may, especially with the immunotherapeutic protocols, you may not see much at about 3 months, and maybe not even much at the 6-month mark. That lady that I presented earlier, that was a 1-year protocol that ultimately then brought this type of profound reduction in size and enabled a partial nephrectomy. So that's a very valid point.
All right, thank you so much for joining us so early in the morning out there.
Thank you for the opportunity and for the kind words. It's been it's been wonderful having a chance to give the talk. Thank you.